Well, thanks for everybody for coming today. We got a lot of stuff to talk about and hoping that you get out of this lecture what you came for. We all are here to talk about the bad side of things, and that's arthritis. Exact causes of arthritis are not known. A lot of research say that 40 to 65% of all hip arthritis and knee arthritis, there's some genetic role. So a lot of times patients will have family members, their mother, their grandmother, who had arthritis as well. So here's osteoarthritis, usually patients over the age of 50, family history. Basically, like we talked about, the cartilage or the cushioning of the ends of the bones become diseased, and as they become diseased, the bones rub against each other, causing pressure changes in the bone, causing pain, and eventually causing stiffness because patients don't want to move that hip, and then it causes even more pain. So you kind of get in this vicious cycle of pain, stiffness, pain, stiffness. Rheumatoid arthritis is an autoimmune disease where your body basically attacks its own, the synovial lining of your joints. So when that happens, the membrane itself becomes inflamed. The inflamed membrane causes excessive fluid in the joint, and that excessive fluid actually damages the cartilage, leading to pain and stiffness. And then traumatic arthritis, so you have injury or fracture in your hip. You can see here, this is the blood supply of the hip. When you break your femoral neck, or the top of your thigh bone, that blood supply gets disrupted, which can cause the head to lose its blood supply, and then when it loses its blood supply, it essentially turns to chalk and dies, which causes pain. It also, when it dies, it loses its supportive abilities, and the head can crumble, causing pain as well. Well, the goals of treatment for arthritis are threefold: control pain, control pain, control pain. Those are really the first three. And by doing that, we can optimize function. Most patients that have severe arthritis can't do the things they want to do. And then finally, one of the things we like to try to do for patients is educate them about the disease like we're doing today and talk about what the treatment options are. So surgical options, total hip replacement, total surface replacement, hemiarthroplasty, which is partial hip replacement, which we usually reserve now for patients that have hip fractures, hip fusion. So I kind of want to give you kind of a diagrammatic or a schematic representation of what we do during a hip replacement. So the first thing that we do is we remove the femoral head. So we dislocate the hip after we've gotten down to the hip socket, and we essentially remove that from the rest of the thigh bone because it's not doing anything. And then reaming the acetabulum. This is a question often: how do you make the cup be able to fit into me? And the most rudimentary thing I can think of is we essentially use a cheese grater to remove the arthritic bone from the hip. So it's a spherical reamer that's on a drill, then we remove the arthritic bone away to make that perfectly round, and by making it perfectly round, we're able to fit the acetabular component, or the cup, into the bone. On the thigh bone side, the femur bone side, we have to prepare the bone for the implant. And then once we get there, we put a trowel in, and we actually locate the hip with trowels in and see if we like the length of the joint, how far the leg is away from the body, and how stable it is. And then finally, once we were happy with that, we put the real deal in. But basically, that will grow in, your bone will grow to this stem, making it essentially part of you. The heads are what we call modular. So in the old-timey total hips, you had a one-piece or monoblock stem where everything kind of came together. Now the heads are modular. So if you need to adjust how long the patient is, how far away they are from the thigh bone, then you can do that with the different heads. The heads also come in different sizes depending on the patient, depending on the setup. Here's a stem that has a big metal ball, so you can see how much larger that is, kind of more like your own hip, but they're modular, so they're able to change those out based on the patient's needs. And once you do that, you have the complete hip. The one thing I didn't mention in this is the bearing surface, which is the plastic. So you can see in this picture here, you have a piece of plastic that goes inside that metal. And the bearing surface is really the rate limiting factor on how long the hips last. because it's just like, you know, having 100,000 mile radial tires. They're eventually going to wear out. So what we've done as orthopedic surgeons and orthopedic biomaterials researchers is try to figure out how we can make this part last longer. One of the solutions is alternative bearings. And one of the things that's getting the most press right now for the wrong reasons is a metal-on-metal articulation, which you have a big metal ball and a metal cup. We also have a ceramic cup on a ceramic ball. We can put a ceramic ball on a plastic ball. We can even put a plastic ball on metal and put a ceramic ball inside of that. So there are multiple options. Some of the things people often ask is about what can I do after, and these are some generic things. We typically try to avoid any impact activities. Patients will often ask about dental prophylaxis or antibiotics before dental work. This is a very important thing. The American Dental Association recommends 2 years post-total hip or total knee, or really any prosthesis, that you take antibiotics prior to the procedure for 2 years. $1 million question is, how long will my hip last? And it's multifactorial. I mean, we got patient issues. For some reason, I'm not really a mechanic, but I always come back to car analogies. You know, I tell patients sometimes if I have a Ford pickup truck and I have a 16-year-old go out and drive that every day, or I have a 68-year-old go out and drive that every day, the 16-year-old is probably going to wear that out a little faster. Okay? Same thing with your hip. If you're crazy on it, if you do things, you can affect the longevity of it. The surgeon and the surgery has a great effect on how the implants are put in. Implants that are put in improperly can lead to quicker wear. Quicker wear can lead to needing a revision faster. Putting implants in improperly can lead to dislocation. Dislocation can lead to needing a revision. So there are things that the surgeon can do, and then once again the implants. All these factors come into play. Once again, I tell my patients we hope to get at least 20 years out of the current hip that you have. And with close follow-up, we can make sure that if anything needs to be done before then, we can do it before it becomes a huge problem. Minimally invasive total hip. So what's the big deal about this? Question is, does it really lead to faster recovery? I think so. Is it really less surgery? And this kind of depends. One of the things I always tell my patients is that length of the decision depends on the size of the patient, the size of the implant. Okay. So how do we get there? And the old saying, there's multiple ways to skin a cat. There's multiple ways to get to the hip. The anterior approach. There's really no scientific evidence of long-term superiority. The short-term benefits are only in small studies, and it's not ideal in every patient. So when I look at this slide, I think, oh, Dr. Ponder thinks the anterior hip is stupid, but I don't. I think it's a good surgery. I think it works in certain patients. But when we're comparing, a lot of times, the anterior approach, as far as rehab, we're usually comparing this approach to this approach, a big 9 to 12-inch incision posteriorly. And most high-volume hip surgeons that do it posteriorly don't do that. They do a 3 to 3.5-inch incision. And so when you start comparing apples to apples, the benefits may not be there in every single patient. So minimally invasive posterior total hip arthroplasty is also a possibility. We have new instruments and surgical techniques that allow us to minimize the disruption of tissues around the joint, and once again, a smaller incision compared to the conventional incision. The other good thing is the implants that are used are existing improving designs, both in the anterior and the posterior. There have been some tweaks to some prostheses to allow the anterior approach to be more achievable in some people's hands. This next picture may have some blood on it, so if you're queasy. So the goals of mini incision are to minimize blood loss, shorten your hospital stay, decrease the pain involved in rehabilitation, lower the overall time to return to normal activities of life, and allow the patient to realize the potential cosmetic benefits of a smaller incision. So this is kind of, and the scale is a little bit off, because this is really zoomed in, but this is a 10 to 12-inch incision, and this is about a 3-inch incision. So you can see you're able to do the same thing through a smaller incision with new instruments, which then lead to these things. Better cosmesis through smaller incisions, less pain, faster recovery, better functional results, and shortened hospital stay. And all these things have kind of borne out in minimally invasive surgery as the positives. The things that have really come out of minimally invasive surgeries are we realize we can do more aggressive rehabilitation, and patients are able to get up and around much quicker. We've learned a lot more about intraoperative soft tissue management, which has also allowed us to do this, the more aggressive rehabilitation, and have made patients happier. The pain management has been a huge thing in the MIS, which is minimally invasive surgery, because we know that if you control pain, it makes you able to do your rehabilitation much quicker. So this is probably one of the best things we've learned out of doing minimally invasive surgery, and then earlier return to function. Now I want to talk about hip resurfacing. Hip resurfacing is a total hip replacement. We were still replacing the ball and the socket, but instead of removing the neck down here and putting a stem down, we essentially recap or cap the end of the thigh bone with a metal ball that's actually cemented to the bone. The thing that I often tell patients about hip resurfacing is it is the most maximally bone conserving. We take the least amount of bone. However, this is a lot of volume, and to be able to do this surgery with all this bone still in place, it's maximally soft tissue invasive. So patients that have hip resurfacings, they have to have those 8 to 10-inch incisions. They have to have more of their tendons taken down in order to do the surgery correctly. Only a small percentage of patients qualify, not everybody is a candidate for this. And it has its own unique pros and cons. Because you're saving this neck, one of the biggest complications that sometimes happens with hip resurfacing is people can have fractures of the neck. Another thing that can happen is that when you're cementing the head on, the cement gets so hot it kills the bone that it's supporting, and over time it will subside. So there are things that you have to take into consideration when a patient presents to you, or you're a patient, in determining whether or not you may be a candidate for hip resurfacing. But you can see, obviously, once again, maximally bone conserving. This is a total hip. This is a hip resurfacing. And then kind of, in my opinion, the best in between are some newer technology called neck sparing stems. And this is essentially bone and soft tissue sparing. You're able to do it to the same incisions, but instead of making your cuts way down here, you're able to spare the neck. And it makes the minimally invasive surgeries easier. There's a lot of enthusiasm in the orthopedic community about these stems. There are other benefits with the stem. When we're able to save bone, we're able to load that bone. If we're able to load bone, bone can be stimulated to grow. So in animal studies and in what are called finite element analysis studies, it shows that the stress on the bone is actually good, that it causes bone to be stronger around the implant. This is a model of the neck sparing stem, and what you can see here, instead of removing essentially all of this bone, you're able to save that, and instead of the stem going way down here, it only goes to about there. So that allows you to, once again, save more bone. So that 20, 25 years from now, something happens, you need to replace this, you can just cut below that and hopefully go back to a standard total hip. And then I wanted to mention, for complete mistake once again, is about the DePuy hip recall. But this is an example of the ASR, and what you can see, it's a metal on metal articulation. The problem with this hip is really inherent to this particular design. The problem with this design is this cup is not hemispherical. It's very, instead of being 180 degrees all the way around, it's less than 150. Because of that, if it's put in at too steep of an angle, people were getting a lot of loading of the edge of the cup. Because they were getting loading of the edge of the cup was either loosening, or they were getting excessive wear of the metal debris. Excessive wear of the metal would cause some reaction. That reaction was causing pain and problems, and so they took it off the market. So it's really a design problem with that particular implant, more than a problem with metal on metal, more than a problem with hip replacements in general.